Good morning. My name is Stephanie Curry, and I am the critical care scientist here at Rural Papworth. This morning, we're just going to finish up with our lung ultrasound presentations for point of care ultrasound. I know that I think we're expecting to undertake the vascular teaching this morning, but for consistency, I'd just like to finish the interstitial syndrome aspect of this lung ultrasound teaching. So if it's okay with everyone, I think we will just go on with that. Just to get started, just a little note about lung ultrasound itself. So in the past, I guess lung ultrasound really hasn't been traditionally used for assessment of lung, although more so now than historically. The reason really for that is because from an ultrasound perspective, ultrasound is conducted very well through superficial structures. So we're talking about skin, fat, muscle. But actually, a really poor imaging quality is created by the aerated lung itself, just because of the acoustic mismatch between the ultrasound waves and the air. It just tends to scatter and create a lot of artifact pattern. However, in development of lung ultrasound as an imaging technique from an acute care perspective, actually lung ultrasound itself is based on interpretation of a number of these artifact patterns and appearances within the aerated and non-aerated lung itself. Just as an overview, the benefits of lung ultrasound. Lung ultrasound is fantastic. It's one of the most practical and useful imaging techniques I think that we have within the critical care, acute care environment because it's very hands-on. It's an immediate bedside exam that we can do. It's relatively short in duration in regards to the imaging technique itself. It's not like a really long and complicated cardiac exam that you might be doing to identify pathology. The actual assessment of lung ultrasound can be done relatively quickly at the bedside itself. It's non-invasive, it's very safe as a technique. As we know, ultrasound has no distinguishable negative consequences. It's repeatable and it's really easy to perform in regards to new users within the critical care environment. It's got a really high intra and interoperator rate of reproducibility and reliability, and it's got a relatively short learning scope. And if you know a couple of basic techniques, and you can become pretty proficient pretty quickly. It's really versatile and a really valuable diagnostic tool. So, and not only that, within our environment itself, from a point of care perspective, the imaging acquisition that you can achieve, you can utilize any of the probes that we generally have available within the critical care environment. So, for example, the linear probe is probably one of the more convenient probes that we could utilize to visualize the superficial structures from the lung point of view. But also, it's very easily available because we're using it for all of our vascular access procedures. Curvilinear, a little bit more versatile in its imaging capability from the lung perspective. We can use it for both the linear aspects that we would, the same way that we would use a linear probe looking at the really superficial structures, but it also gives us that frequency that we can actually see some of the deeper structures if we're looking to identify consolidations or pleural effusions within the lung itself. Phased array we can use, but generally speaking, the phased array probe is used as an adjunct to the cardiac exam that you might be doing as an additional imaging of the lung, and not necessarily your go-to probe that you would use to image the lung as a whole. Just one thing to note in regards to the basic point of care ultrasound machines that we have. Generally, they're very well suited to imaging the lung itself because we're not having to utilize any of the more advanced techniques that kind of get rid of any of the artifact patterns. So a basic machine actually can be better for imaging of the lung because we want to make sure that all of those features that would decrease any of the artifacts. So if some part of the compound imaging, the harmonics, the speckle reduction, we want to leave all of those in play. It gives us quite a grainy image a lot of the time, but the artifact patterns can be more easily interpreted if we don't have any of the software processing features on the machine itself. So point of care ultrasound is more than suitable for undertaking a lung ultrasound exam. But what do you actually looking for when we talk about our lung ultrasound imaging techniques? So we'll go through these in a little bit of detail just to kind of go over the basics again. But we basically can keep it to looking at our landmarks, which would be our pleural line, our bat sign, our diaphragm. I'll go over those in detail with each slide. And then we're looking at our reverberation, our artifacts, and our patterns that we can start to use to interpret some of the pathologies that might be coming out of the lung itself to try and distinguish pleural effusions, pneumothorax, consolidations, but also not listed here probably things like interstitial syndrome, aeration patterns that we might be seeing, and some of our decreased aeration lung patients as well. So if we start right from the beginning, if we look here at our the first feature that you're generally going to come to from a lung ultrasound assessment perspective is one of the landmarks that you need to identify first and foremost is your pleural line. So in a normally aerated lung, the pleural line should actually be the only detectable structure that you're actually visualizing with the probe itself. You can see here with the image that I've got on the screen, it's just a linear image, and there's a really bright white hyperechoic pleural line that you're seeing. This is actually a combination of both the visceral and the parietal pleura that are combined together. And in live motion, where you're seeing the movement of this pattern, you should be seeing this here. Yeah, so you should be seeing the movement of that pleural line as it's opposed to the chest wall. So between the visceral and the parietal pleura, the pleural line, if you're looking right at the very top of that image that we're seeing just below the subcutaneous tissue and muscle, we're seeing the movement of the pleural line with respiration. But how do you actually know that that is in fact the pleural line? One of the most important aspects in order to distinguish that that is in fact the pleural line that you're looking at, other than the fact that this one's actually moving, sometimes they're not, and that's just as informative as it not moving, is you want to identify some structures around it. And that's where we talked a little bit about the bat sign before. So we're looking at the landmark images that we'd be seeing. We've discovered or we've identified something called the bat sign. I'm not making these terms up. These are terms from other individuals who make these up, Daniel Lichtenstein notably. So the bat sign, actually, if we were to draw it out here, is actually the combination of the rib space. It's actually the visualization of the pleural line between the rib spaces. So we need to be able to distinguish very clearly what we see as the rib, the rib above and the rib below that pleural space that we're actually investigating. And you see I've marked them off quite clearly here where you can identify that you've got a rib above and a rib below, and then the pleural line is going to sit just under that rib space, which is going to give us an indication that that is in fact the pleural line. It's really important to be able to distinguish and to accurately identify that that is the pleural line. Because sometimes what you're trying to identify is the pleural line's not moving. And if it's not moving, that's where you need your landmark techniques to say that this is where it should be and this is where it is moving. So, moving on from the pleural line and the interpretation of the pleura between each of the rib spaces, as we were discussing before, the next and most important landmark that we will visualize within our lung ultrasound exam is that of the diaphragm. So the diaphragm you will find by positioning your probe on the lateral mid-axillary line of the chest wall. I would just say that your diaphragm's higher than you think it is. So just make sure that you position your probe at a high enough level within the rib spaces in order to visualize that diaphragm. Also, it's much easier to visualize the diaphragm on the right hand side of the patient than on the left hand side, and that's purely because the liver makes a better acoustic window for visualization of that diaphragm itself. Looking at the diaphragm as a structure, what we will see with our ultrasound is that the diaphragm is actually made up of three very distinct structures that you can visualize quite clearly. You've got two layers that are more echoic, so you'll be able to visualize them better. They're much brighter in appearance, and that's the layers of the pleura, of the thoracic cavity, and the layer of the peritoneum that they're sliding against one another, and it makes a really bright white hyper-echoic image. Within that diaphragm itself, if you were to focus in and zoom in on just visualizing the diaphragm, you might see that there is a more hypoechoic, so it's less bright, and that's a layer of muscle between the two layers of the pleura and the peritoneum. It's important that you can identify the diaphragm on both the right and the left hand side, because we can use some of the artifact patterns that are generated within that area to give us some further information about some aeration and some or some pathology that's going on within those regions that we'll talk about a little bit later when we talk about the artifact patterns that are being generated. Next thing that we should talk about here is our artifact patterns that are generated from these landmarks that we've been able to identify. So the first and probably most obvious would be an A line. So A-lines are actually reverberation artifacts that are reverberating off of the only distinguishable feature that we're seeing within the lungs, which is the pleural line, which we talked about earlier. So the pleural line with an aerated lung, positioning your probe on the chest wall perpendicular to the pleural line itself should give you a equal reverberation artifact pattern, which are known as A lines. So A lines are essentially just the reverberation of the pleural line that we've identified before at equal intervals throughout that aerated lung tissue for as far down as you're able to visualize on the lung itself. You know that it's an A line because the A line should be the distance between where your probe is at the chest wall and the interface with the pleural line itself. So the distance between the probe at the chest wall and the pleural line should be the equal distance between each of the A lines that you're seeing below. So in normal circumstances, what would that look like in a movement pattern? So if I were to come here onto this, you're seeing that the A lines are the pleural, are the horizontal lines that are parallel to the pleural line at the equal intervals from the edge of the chest wall all the way down through our aeration pattern. And it's quite clear to see in this picture. You've got your normal bat sign. You're seeing that you've got a rib shadow just there superior to the pleural line or the pleural space that we are investigating. You've got a rib shadow below, and there's a little bit of a beeline coming in here and there, but we'll touch on that next. And then you've got in the middle, you've got the really bright white line of the pleural line, and then the equal distribution of those A lines all the way down throughout that lung field. And what's that telling us? Essentially, that's telling us that we've got a well aerated lung, and that we've got opposition of the between the visceral and the parietal pleura up against the thoracic wall. So it's giving us a lot of information just from visualizing that one artifact pattern and our landmark of the pleural line. It's giving us a lot of information. It's telling us that this area of the lung is aerated. This area of the lung is, there's not a pneumothorax there because there's connection between the two pleura, and there's movement of that pleura as well. So there's change in the volume of the lung tissue underneath. So there's aeration of that lung. And this is what you should be seeing in a normally aerated lung. However, it would change slightly if we looked at a deaerated lung, or a lung that has more fluid than air. And what we would start to see is these are called B lines. So B lines is in direct opposition to what we would describe as an A line, where you've got the horizontal lines that are generated from the pleural line and coming down equally within that aerated field. B lines are laser-like, and they're vertical lines, again, originating from the pleural line, because all of our artifact patterns in this case are being generated from the pleural line. Everything underneath that is artifact that we're trying to interpret. And that B line that we're seeing in this picture, these are very clear, distinct looking B lines. You can see that they're being generated from that pleural line, and they're moving all the way down within that echo field that we're seeing until the end of the echo field that we're looking at in this case. But in real time, what does that look like? So if we were to come here to this image, again, we're visualizing some of those landmark structures that we were seeing before. So we're seeing again, we could identify, if we needed to, our bat sign. So you've got the rib shadow that you're seeing above, and then you're seeing just a hint of the rib shadow below as well. You've got the really bright white hyperechogenic line of the pleural line. And then originating from that pleural line in a vertical fashion, you've got B lines that are generated. So the most important characteristic that you need to identify with a B line is that not only is it originating from the pleural line, but it's being visualized at the edge of the ultrasound field that you're seeing as well. It needs to come all the way through that ultrasound image that you're looking at. They need to be well defined to be truly identified as a B line and not just a general artifact pattern. You'll see with respiration, the B lines are moving with the pleural line movements because they're being generated from the pleural line. And with changes in aeration, you'll have more B lines developing with the less aeration you're having within that lung tissue itself. So more A lines, better aeration. More B lines, worse aeration of that lung. Because essentially what you're finding with this reverberation or this artifact pattern that's being generated is B lines are an interaction between the air and fluid within the lung and the reflection back from that ultrasound wave generating this B line. So the more B lines you have within an interstitial, within a pleural space, the less aeration you're having within that pleural space itself. Important to note B lines within each of the interstitial spaces. it can be common to have one or two B lines within the interstitial space, within the pleural space that you are investigating. But the when you start to have more B lines than you're able to visualize in A lines, that's when you're having that flip, that change in that aeration pattern that is going to start to indicate some pathology that's going on in there as well. So finally, the next, we can call it a landmark, but we can also call it an artifact pattern that's being generated, because before we were talking about actually the visualization of the diaphragm itself, but actually what do we want to see with a diaphragm? We want to see a couple of things with the diaphragm. We want to see that the diaphragm is moving, so we're looking for excursion of the diaphragm, so movement of the diaphragm in the fashion that you would expect with the ventilation pattern that you're observing in the patient. But also you want to see that you've got an aerated, or in some cases deaerated lung, or in some cases no lung at all because you've got pleural effusion. You want to see that movement of the lung field across the diaphragm that's going to obstruct your visualization of the diaphragm. And that's what we're seeing here. So this is what is known as the curtain sign. The curtain sign is the obstruction of the view of the diaphragm with an aerated lung coming across that diaphragm. In the positioning of this probe itself, this is a curvilinear probe that we've got on the screen, and the positioning of the probe is on the lateral aspect at the approximate area the approximate rib space where you think the diaphragm would occur. Remember, the diaphragm is a dome shape, so it's going to be higher anterior than it is posteriorly. So you need to come up higher than you think on the lateral wall to visualize the diaphragm itself. And the pointer of the probe should be pointing towards the patient's axilla. So the P that's visualized on the screen just here, that means the pointer of the probe is facing towards the patient's armpit, essentially. And as the patient's breathes, you would expect the movement of the diaphragm to go down towards the feet, and the movement of the aerated lung is going to come over and obstruct that image. And that's what we're seeing just here. So visualization of the curtain sign can give us some really useful information about the quality of the lung field at the inferior lung bases. Because, for example, as we're seeing in this picture, where we're seeing a clear obstruction of the view of the diaphragm, we can start to interpret that we've got aeration of that lung field at the lower inferior regions at the lung base. We can see that the pleura are connected because we're seeing that nice pleura sliding with respiration. We can also make some interpretations about the quality of that aeration based on interpretation of the number and the visualization of B lines in that inferior lung region. So in contrast to that aerated lung that I was showing you before, and that visualization of the curtain sign that was coming across and obstructing our view of the diaphragm, with the development of pathology in the lower lung bases, we lose that curtain sign, and we start to more directly visualize the diaphragm throughout the respiratory cycle. But we also see the pathology that's happening underneath. So in this picture, we are seeing some consolidated lung with some pleural effusion as well. And equally, this gives us a lot of valuable information that we can start to utilize. And we'll talk a little bit more about this when we talk about pleural effusions and consolidations in our future presentations. So finally, in regards to the diaphragm and in regards to some of the artifacts, but also some of the movement patterns that we would expect to see, we need to really consider the excursion or the movement of that diaphragm that we should be observing in normal respiration. You'll see here in the image that's playing on the screen now We've got a little bit of a curtain sign that's coming across, but we're really focusing on the view of the diaphragm in this image, because what we're looking at is with respiration, how much that diaphragm is moving in the fashion that we would expect with those breaths. We can use some more advanced features that later on that we can talk about in relation to measuring this excursion or this movement of the diaphragm, and there are some standard values that we should consider. But really what I want you to appreciate now is that with respiration, this movement pattern of the diaphragm as we would expect. Whereas if we were to consider the image that we have on the screen here and the movement excursion of the diaphragm that we're seeing, it's very much reduced in comparison to the previous image that I was showing you. And probably that's to do with some of the pathology that we see underlying on the image. So, just to finish up this introduction to lung ultrasound, I just wanted to go over briefly about some scanning techniques that we can start to implement in order to start to undertake these exams that we're going to be doing. So you'll see on the slide that I have here just some probe positions located on the anterior chest wall at the apex, and then also on the lateral chest wall at the lung bases. So if we were to consider the lung regions, we actually can break up our lungs into our right and our left lobes. And we can further split those or divide those lungs up into our superior and inferior aspects on the anterior, the lateral, and the inferior aspects of the wall. So if you look on picture B that I'm showing you just there, it looks like you've only got one reference point, so you're only scanning within one rib space. In actual fact, that's not true. If you're looking to interpret or investigate a region of that lung, it's very acceptable for you to scan at multiple points within the rib spaces within that region. Depending on the type of exam that you're doing, whether you're doing a very systematic exam for research purposes or whether you're doing it for an evaluation of suspected lung pathology, will very much determine how many spaces within that region you're looking to interpret and how much value that's going to add to your exam. In general, the clinical suspicion will help to guide that diagnostic process and will start to determine the level of the systematic exam that you might be undertaking. So, for example, if you had clinical suspicions of perhaps a pneumothorax, it might be sufficient for you just to undertake a basic 4-zone exam, starting obviously with the apex of the suspected lung, and scanning at multiple points within the anterior superior region of that lung to really get an idea if there is sufficient lung sliding. And then you would want to continue to evaluate at your lung bases just to see if you did have that diaphragmatic movement and if you had that curtain sign, because that could give you some very valuable information about any potential significance of the pneumothorax that might have occurred within that lung. Whereas, for example, if you wanted to consider a pleural effusion, this in the same way, a 4-zone region might be sufficient. Again, looking at the apexes and at your lung bases. But for a more thorough exam, you might want to include an 8-zone region, so looking at the inferior and posterior aspects of that lung base to further examine the true extent of any pleural effusion that might be happening, always comparing bilaterally between your right and your left lungs. In contrast, if you're looking to perform a more systematic exam for determination of lung aeration or for research-based purposes, it would be suggested to incorporate all 12 of those lung regions, again, scanning at multiple points within that region of the lung and documenting any findings that you might have. So, furthermore, in addition to the systematic exams that we can use for investigation of these lung regions, there are also protocols that we can look to that can give us some guidance on interpretation of some of the findings that we're going to find within our exams. So, probably one of the best known protocols for undertaking a systematic exam for lung ultrasound is the Blue protocol by Daniel Lichtenstein, who, if you don't know who he is, he's probably one of the most important players in the development of lung ultrasound. This is more of a basic or condensed version of the Blue protocol, which starts obviously with the pleural line as a starting point, because we know that all of our artifacts and our landmarks are generated from that pleural line and that pleural sliding. And it guides you through a process really of looking at from point to point and guiding you towards a diagnosis of some of the findings that you might find. We'll go through this in a lot of detail when we talk about interpretation of our pathology and looking at especially aeration, but also pneumothorax and to a point as well our pleural effusions. So that was really just a quick introduction into our lung ultrasound, our identification of our key landmarks, our pleural line and our diaphragm, and also the interpretation of some of these, our identification of some of these artifact patterns that we're going to see as we move through our lung ultrasound assessments. I've given you a very brief introduction to some suggestions that you can start to implement for undertaking a systematic exam and guidance towards protocols that might be useful for you for interpretation of some of the findings that you have. In the next presentations that we're going to present, we'll go through some of the key pathologies of pleural effusions, pneumothorax, and our interstitial syndrome with some interpretation of aeration. So thank you very much.